Good afternoon, almost good afternoon, everyone. My name is Lois Mishkin. Thank you for joining us and being part of BIANJ's annual seminar. Before we get started, I just want to remind everyone to enter your full name in the chat. This is our virtual sign-in sheet. If you're going to request CEUs, remember you must attend this workshop in its entirety. Complete the workshop evaluation, and if required by your discipline, complete a post-test. I will be entering that link in the chat for your convenience. Zoom will provide a report of how long each of you stayed in the workshop. CEUs cannot be given if attendance is not verified. Questions are certainly encouraged. Please enter questions in the chat and they'll be addressed at the end of the presentation. This workshop is Pediatric Research Panel, and Diane Simmons-Grab will introduce the first presenter.
Hello. Who we have here is Dr. Renat Sukoff from Rehabilitation and Habilitation Aspects in Pediatric Brain Injury Continuum will be his presentation. Dr. Sukoff is a fellow of the American of Physical Medicine and Rehabilitation, a clinical associate professor, Department of Rehabilitation at NYU Grossman School of Medicine, the interim medical director of the Pediatric Rehabilitation Service, and board certified in pediatric and adult rehabilitation by the American Board of PM&R, that's Physical Medicine and Rehabilitation. And on a personal note, I've worked with him on several cases over the past few years, and I've learned that he's very much an advocate for the individual he's working with, as well as very accessible.
Thank you, Diane, for a wonderful introduction. I appreciate your time and invitation for this interesting seminar for Brain Injury Association of New Jersey. The topic of my conversation, as you can see, is rehabilitation and habilitation aspects of pediatric brain injury. I think that's very important for the participants of this conference to realize the peculiarities of pediatric brain injury rehabilitation at large, and in general, understand the specifics of the subject. So acquired brain injury in children, let's start with epidemiology and facts. So the CDC statistics estimates approximately 23,000 hospitalizations. There's a decline of hospitalizations over the decade. However, the mortality from the TBI, and I'm going to specifically refer in this specific conversation, not about the mild brain injury, but acquired brain injury that is a little more moderate to severe. And mortality is about 9 pediatric deaths over 100,000 population. Incidence is higher in children less than 5 years of age, and the children of 15 years of age and older, however, have higher rate of hospitalizations. Interesting facts that boys more than girls have been being affected by traumatic brain injury, and boys older than 10, certainly the twofold number than the girls. So there are other interesting statistics that I can go over with, but I think that it's not the major subject of this talk. So let's talk about etiologies of acquired brain injury in children. So it obviously depends on the age group. So in the children of younger age, non-accidental injuries in infants, falls in children below 5 years of age, and some people think below 10 years of age. And then overwhelming number of motor vehicle accidents taking over. So it's also important in this day and age to discuss some aspects in relation to faults that comprises 9% of traumatic brain injury in children less than 5 years of age, and also the incidence of child abuse that is a separate discussion, which probably requires additional conversation an additional topic in children 1 year of age because of pathology and different presentations. Also, I should not really be not to mention firearms. The firearms cause of death in children 15 and older. We hear every day some sort of report in the news that certainly indicates that firearms can really be a significant from in children of 15 and older. The accessibility of guns. So, what is the imaging in acquired brain injury? Because obviously brain injuries at this point is associated with CT scans, MRIs, and the hallmark of the brain injury is diffuse axonal injury. A variety of different MRI protocols that exist, including the diffusion weighted sequence, the susceptibility weighted sequence that allows us to really describe better the pathology. Then there is overall high rate of subdural hematomas, an overall picture of CT scanning of the head, and you have to be very fine-tuned to the clinical needs of the patient when you the patient on the site. So obviously the subdural hematomas cannot be missed. Retinal hemorrhages that is typically typical for the brain injury, acquired brain injury, usually a severe and diffuse. So the major goal for traumatic brain injury in general is to prevention of the primary injury and decrease a secondary injury. So for that reason, there are a lot of papers that have been published, on prevention of the traumatic brain injuries. And obviously, the risk aversion is the most important factor here. Just make sure that there will be no specific problems with the playgrounds, and the playgrounds can be padded, and then make sure that their supervision of the children below 5 and sometimes 10 years of age, and obviously motor vehicle accidents, which currently at this day and time, the cars became safer, but they still cause significant cause of acquired brain injury. So, what are the principles that we are working with children and brain injury? It's a maintain perfusion, control intracranial pressure, prevent hypertension, hypoxia, and hypoglycemia. These are the major goals for the acute management. And outcome is largely dependent on initial response measures at the transport and management in trauma center. So, and there are a lot of papers that have been published in reference to that. I should also mention that I'm talking about specifically here about traumatic brain injury, but there's a huge number of non-traumatic brain injuries. It probably requires additional conversation, but an additional topic of discussion. And among this type of non-traumatic brain injuries that can be mentioned, at least in this conversation, is AVMs, empyemas of the brain due to infection processes, cardiac disease that has connection to the brain with arrhythmias, endocarditis and cardiomyopathies, moya disease, et cetera, et cetera. So also, in addition to that, there's a bunch of recently papers that have been published about CT scanning, and there's an issue of how to score the risks. And the Rotterdam Head CT score has been recently published, and it's interesting conversation in terms of the radiology findings and how to prognosticate the outcome. So, as I have mentioned, the various etiologies of acquired brain injuries are important subjects, and I'm going to mention some of it as well. I have already mentioned to you the cardiac causes, and I mentioned to you the empyemas and AVMs, but also anoxic brain injuries. And the anoxic brain injuries, obviously, with respiratory issues, trauma, and arrhythmias. I should also mention here near drowning and near henning these are the very devastating injuries, has its own pathophysiology and presentation. And I think that it's beyond the scope of this discussion, but it has to be absolutely mentioned as a part of the acquired brain injury in pediatric population. Then there are other etiologies like cerebral arteriopathies and moya diseases, puff smoke, which is evident on the imaging studies. Now, let's go to the this algorithms that has been published in Brain Trauma Foundation and recently has been updated. And this is one of the diagrams. I don't want you to remember that because it's hard to even see, but this is a whole algorithm in terms of how to manage the brain injury in acute settings. And some of it has been outlined in this article of Management of Pediatric Severe Traumatic Brain Injuries, 2019 Consensus and Guidelines from Pediatric Critical Care. So the mainstay for acute traumatic brain injury treatment in children is, like in adults as well, is ICP target less than 20, and then use of hyperosmolar therapy and use of a variety of different medications, CSF drainage, hypothermia, and decompressive craniectomy. Needless to say, there's a growing body of evidence, but not a confirmed body of evidence in some of the aspects of it. Certainly, the management, the goal for the overall management in this country and other countries is to kind of standardize the approach for the care management of traumatic brain injury, which I think that we're slowly but surely achieving. What is interesting that there are more and more advanced neuromonitoring that is being propagated in the research, and this type of approaches, microdialysis, which is placing a catheter into the brain parenchyma, allowing sampling of interstitial fluid components such as glucose and glutamate, is very promising, and it allows to prognosticate early on the recovery and perhaps the management of the condition, such as traumatic brain injury. Electrophysiology monitoring, if it's available, it's including electrocortigraphy, which is placement of electrode arrays in the surface of the brain, making sure that there's no hyperexcitability. Some of the brain oxygenation studies and also have been entertained in the most recent literature studies that has hopefully will gain traction and will standardize approach for the risk management and management of the brain injury patients altogether, specifically in pediatric population as well. So what do we have now in terms of evidence for rehabilitative interventions in an acute care settings? Well, we don't have too much, but we do have certainly evidence that early mobility in pediatric intensive care unit settings is helpful, and it's usually a multidisciplinary, interdisciplinary approach. Patient will be lucky to have a team of rehabilitative specialists, highly trained pediatric therapists that can actually utilize their skills to employ early mobility and early rehabilitation and habilitative measures. I have certainly gained some appreciation throughout the years of my career, where I can see that the team of highly trained rehab specialists really makes a lot of difference in terms of overall recovery and overall both motorically, physically, cognitively, speech-wise, vision, name it. I think that this is very important subject. An additional very important subject that we have very sure and more valid type of data is nutritional support. The brain consumes a lot of energy, and certainly nutritional support within 72 hours after the injury is of utmost importance. And you can see some of the patients that are really oozing their pounds and kilograms, out, after brain injury. They have to be really nutritionally supported. So let's talk about overall what do we have as a brain injury patient. What kind of sensory impairments do they have? And I'm going to start with one of the major ones is vision. Vision comprises 60 to 65% of the brain. It's the most common impairment that you can actually appreciate in patients with brain injury. And you can see oculomotor deficiencies, convergence and accommodation deficiencies in all kinds of brain injury. And it's one of the hallmarks, for example, of mild traumatic brain injury in concussion, but also is so much evident in acquired moderate to severe brain injuries that are traumatic origin. So visual field cuts, these are very common presentation. Loss of color vision, diplopia, visual tracking deficits, visual processing disorders that are going to linger on for years and require additional support from the staff that is going to take care of the patients in outpatient setting. And in this slide, it says about 50% of the brain involved in visual processing of visual information. I think that, it may be even more so. And this type of information is obviously controversial because you cannot really ascertain the specific data, how much vision is being involved, but certainly more than 50%. There's problems of visual sensory integration processing disorders that are certainly obvious in children that had traumatic brain injury, and vision evaluation is of utmost importance, specifically evaluations of measurement of visual acuity, visual fields, contrast sensitivity, movement perception, color vision, and overall the brain injury strategies for the rehabilitation and habilitation of these patients are focused on compensatory strategies such as corrective lenses, restorative strategies, including vision therapy. I think that vision therapy is a very much evolving type of field. We don't know too much about the way how it's actually being restored. We are collecting more and more data, and we extrapolating some of the data from adult population. It's very important to mention that it's these patients with traumatic brain injury should be evaluated by neurooptometrists and neuro-ophthalmologists. So, as I mentioned, oculomotor vision therapy, it's a multimodal approach with the goals to improve oculomotor function. This is a very tedious process that requires a lot of skills and a lot of collaboration with a variety of different specialists and recognition by the community at large, and certainly needs more research. So let's talk about hearing, another very important aspect of pediatric traumatic brain injury. It's they're kind of divided into basilar skull fractures, and it's interesting that there's also skull fractures that in children below 3 years of age called growing fractures. So it's important to take an X-ray. Temporal bone fractures can lead to the conductive hearing loss and is more common than sensory neural hearing loss in this particular type of fracture. Overall, there is also impact on central processing deficits, decreased ability to localize sound, disseminate sound in a noisy background, distinguish multiple sources of sounds. So it's really debilitating for the child after the brain injury because of the cacophony of different sounds that they cannot distinguish otherwise. That actually by itself can lead to auditory processing disorders and in various age groups, and I think that it needs to be studied even more. because maybe various age groups can be susceptible to this type of hearing deficits in a much more different fashion. And it certainly it can lead to nausea for specific sounds. And I should really tell that anybody who comes with a suspected brain injury, even a mild one, should and has probably some level of or had a temporal bone fracture, basilar fracture, should be imaged and make sure that there's a appropriate referral to ENT. I've seen in my practice, because of outpatient and inpatient settings, I've seen the situations where there were fractures that had been missed and certainly had an impact on hearing, because hearing is a bilateral function and it certainly can be easily missed in clinical evaluation. So taste and smell. That's an interesting topic itself. Obviously, it's the cranial nerve. One has direct connection to the brain. It's the only one that actually goes directly from the nose to the brain. And obviously, anosmias and hyperosmias are very common in brain injury. People are suffering from that for years, and sometimes it can be very debilitating. Less so for the taste, and on the right hand, you see the different taste buds that exist. I've seen both in my clinical practice, and obviously the mostly taste, mostly smell is very debilitating for some of the patients that cannot really appreciate the smell of food, that enjoy the smell of flowers, etc., for quite a bit of time following the injury. So there are other complications that I should really mention in terms of the brain injury, and certainly seen in acute and post and rehabilitation settings. It's hydrocephalus, and it has to be really distinguished the hydrocephalus or ex vacuo ventricular dilatation, or hydrocephalus ex vacuo. The two causes of ventriculomegaly, and intervention is necessary for hydrocephalus, but not for ex vacuo ventricular dilatation. Ex vacuo dilatation describes ventriculomegaly secondary to loss of brain parenchyma, specifically periventricular white matter due to injury. So ex vacuo ventricular dilatation does not reflect increase of ICP, and there are no associated acute changes in clinical status. Imaging studies in case of ex vacuo dilatation typically include diffuse cerebral atrophy and sulcal prominence. So one of the most common causes of brain injury complications are the seizures. And seizures can be divided into immediate, early, and late. Immediate seizures occur within 24 hours of injury. Early seizures are within 7 days, and late seizures go on more than 7 days post-injury. So interestingly, post-traumatic epilepsy is diagnosed in the presence of 2 or more late seizures. And in the recent review of studies, the incidence of traumatic epilepsy is approximately 22%. So another fun fact, quote unquote, is that early seizure prophylaxis does not prevent development of the late post-traumatic seizures. Typically, the post-traumatic seizure prophylaxis lasts about 7 days. There are a variety of different protocols that exist. I'm not going to go on into that, but certainly some people recommend only 7-day prophylaxis, and some surgeons and some neurologists are recommending even longer. Paroxysmal sympathetic hyperactivity. This is a very severe type of a constellation of symptoms, and it's a lot of unknowns there. How does it happen, and how to deal with that? But certainly, it can be very devastating. I've seen several cases like that, but it's also very important to understand that we try to understand how to manage this type of hyperactivity, sympathetic hyperactivity, using less medications, but medication management is very important here. So interestingly, that anoxic brain injury has longer duration of hospitalization and worse functional outcome. I think that it's kind of a more self-explanatory in a way. So how do we try to kind of assess the functional outcomes? And certainly, Glasgow Coma Scale has been around for a while, and there are a variety of different tools that have been now verified and kind of could be more valid. And some of the tools that we use is global outcome scales. There's extended pediatric version. There's a King's outcome scale, childhood injury, Rangelo's Amiga scale, and PDCAT. So these are the variety of different scales. For example, Glasgow outcome scale have 8 categories. I'm sorry, King's outcome scale of childhood head injury have 8 categories of outcomes spanning from death and vegetative state to good recovery. And Glasgow outcome scale extended pediatrics has been designed as an interview measure, but has also been scored through retrospective review of clinical information. So it depends on the center and depends on the way how people would like to utilize this functional outcome scale, but certainly helps out to prognosticate the outcome for the children with brain. So the topic of the next discussion is going to be by Dr. Yalamanchi is going to be disorders of consciousness, and I'm not going to dwell on a bit about disorder of consciousness. But I would like to refer you to the article that has been recently published in the Archives of Physical Medicine and Rehabilitation, Clinical Features of Disorders of Consciousness in Young Children, published by Dr. Alvarez and from Department of Neuropsychology at Atlanta and also Johns Hopkins University. This is a very fundamental study that described the disorders of consciousness in children between 6 months to 5 years of age. Very tedious and very good study. And but I would like to go over some of the aspects of the definitions. Coma is a lack of sleep-wake cycles, lack of awareness of self-environment. Vegetative state, also called unresponsive wakefulness syndrome, has sleep-wake cycles, lack of awareness and of self-environment. And minimally conscious state has sleep-wake cycles, has minimal awareness and self-environment. Patient can emerge back into conscious state, usually evidenced by reliable communication and object use. So that's very important. So these are the diagrams that has been adopted from this specific article. And you can see that in vegetative state, there's a reflexive and non-purposeful movement, non-sustained voluntary, reproducible, or purposeful behavioral response to stimuli, and a variety of different behavioral features and evaluations have been mentioned on the right side of this table 1. Oh, I would like to mention something that is really interesting, and the way how the dynamic of the disorders of consciousness has changed throughout the years. It's a concept of minimally conscious state that can be defined as minimally conscious state minus, where there's inconsistent orientation to noxious stimuli, visual tracking, or appropriate response to emotional stimuli. Excuse me. And a minimally conscious state plus, which is a higher cognitive abilities evidenced by command following, comprehensible verbalization or gestural and voiced yes and no responses. There's also beyond minimal conscious state, the conscious state that is marked by the ability to demonstrate functional use of 2 objects of an accurate yes and no response to 6 visual or auditory related questions. These are very important concepts in terms of the emerging patients from the disorders of consciousness state, and it's defining that is of utmost importance for the clinicians and actually obviously for the parents of the child and the child himself or herself. So coma recovery scale is used for the children 1 to 4. Guidelines emphasize counseling families that history and prognosis with prolonged disorders of consciousness is not well defined. Many children emerge to the conscious state, and this is a good news. Dramatic etiologies and higher level of functioning at admission and discharge are associated with better outcome, which is also good for the patient. But mindful of the fact that there's also age groups. The younger the child, the less of a ability for them to have a better outcome functionally. And it's interesting that the children between 6 to 12 years of age have those who had brain injury had worse type of outcome 10 years after than the patients after the 15 years of age and above. So 16 to 20 years of age and above. I apologize. Intensive rehabilitation program and interdisciplinary approach it is the most important factor in rehabilitation of the children, and and let's talk about some of the domains that pediatric traumatic brain injury has to be we have to pay attention to, and obviously the issues of attention and executive function, issues of learning and memory, processing speed of information is very important to address right away, and certainly multimodal I would say modular type of approach and multifaceted type of approach is very important to address these issues in structured rehabilitation settings. And that's why the rehabilitation settings has to be, we have to have a continuity of care for that, from inpatient to post-acute care for outpatient, staffed with appropriate specialists who can actually understand the pathology. So, this is a very important subject across the board, and I think that it's important to address it in a national and international level. So I should also mention, and we also, all of us aware about a variety of different issues that are related to the comorbidities that's associated with recovery and actually traumatic brain injury. ADHD, anxiety, these are the very specific entities that you are dealing with before and after the brain injury. There's some articles indicating that the patients with ADHD prone to have traumatic brain injury much more common than children without it. Anxiety can certainly be developed after the brain injury, and certainly this is something that needs to be dealt with both medication-wise and with neurobehavioral specialists, and it can linger on for years. There's personality changes and depressive episodes. These are the very significant common denominators for emotional behavioral health, and the role of neuropsychologists and psychologists should not be understated, especially in the current models of healthcare delivery for the children with brain injuries.
Dr. Sukhov, 5 minutes, please.
So thank you. Okay. There are also social aspects of care that are important to understand. Its ability to process complex language and processing speed, executive function certainly is being compromised after the traumatic brain injury. Let's talk briefly about the predictors of outcome. These are the injury-related factors, child pre-injury factors, and family factors. So in injury-related factors, we should state about the Glasgow Coma score, obviously the lowest for the worst outcome, length of post-traumatic amnesia, also almost the same correlation, and role of neuroimaging studies. A few studies, imaging studies that actually now evolving and maybe will help us very soon to start prognosticating a bit of recovery from the traumatic brain injury. So pre-injury history certainly is important aspects to emotional behavioral symptoms that exist pre-injury, and that can actually lead to the incident of the traumatic brain injury age. As I mentioned before, the children with 2 years of age have more global impairments, and children from between 12 have worse outcomes than the children from 16 to 20 years of age. Actually, the youngest group have more problem solving and communication problem than actually a little bit older groups. That study actually goes back to 1940s, and it's it's very interesting. I tried to do some review in the past, and it's very very interesting kind of a body of evidence that exists. So family factors, we should mention that the low socioeconomic class, slow rate of recovery, family dysfunction, increased risk of range of and poor outcomes, and post-acute rehabilitation. This is very important aspect, that is for all of us important to discuss. That actually there's some disparities in terms of the inpatient rehabilitation care related to racial status and also the social the staffing of the patients and the issues related to the post-acute rehabilitation, what needs to be done and how you can staff appropriately the centers for the children that recovering from acute traumatic brain injury. It's also related to the funding, to the insurance coverage, and the only fun fact, quote unquote, I would like to tell that less than 1/3 of children receive outpatient therapy within the first year of the injury, which actually I think that's pitiful, and we need to change that. So, so barriers for post-acute brain injury.
I'm afraid I'm going to have to stop you right there, Dr. Sukov. So
Sure.
we can have the other two. I apologize. It was a wonderful presentation, and questions and answers will be after the next presentation.
Sure, no problem.
Our second presentation is based on the REST protocol that was developed at Children's Specialized Hospital. A multidisciplinary team approach to treating children with disorders of consciousness, which will be presented by Dr. Krishan Yalamachi, MD, FAAP, and Danielle Duddy, MOTR. Dr. Yalamachi is director of the Pediatric Brain Injury Program at Children's Specialized. And he's been there for over 30 years and is associate professor of clinical pediatrics at RWJ Medical Center and involved in teaching pediatric and physical medicine and rehab residents from Rutgers Medical School. He has participated in several research studies with Kessler Research Institute. Danielle Duddy has been an occupational therapist working in pediatrics for 13 years. She has worked at Children's Specialized since 2010 and is a certified yoga instructor, hippotherapy certified, and aquatic therapy certified. She has been an adjunct professor at Dominican College and provided professional presentations to Rutgers University and CSH hospital employees. With that, Dr. Yalamachi and Danielle, go for it.
Thank you, Lois. So today's topic is disorders of consciousness and the REST protocol, which was specifically developed at Children's Specialized about 10 years ago. Since morning, we have heard from our keynote speaker, Dr. Fins, who extensively covered disorders of consciousness. So I'll just recap briefly certain aspects of it, and then we'll present our outcome data in the last 10 years. We've been getting about 10 to 12 patients every year who fall into this category, and it's been extremely difficult to document progress and use a scale other than functional scales, which are mostly used in acute rehabilitation. So this has been really a team effort to develop this protocol, and we have about 67 patients so far. Will present their outcomes. So we'll review the disorders of consciousness in this talk, then review treatment and evaluation protocol developed here at Children's Specialized, and discuss REST protocol outcome data. As you know, several scales have been used, which you may be familiar with. Obviously, functional scales we cannot use in this population. The one we have adapted at Children's Specialized is the Coma Recovery Scale revised one, which Dr. Sukov also mentioned. Other places have used several other scales, like the Glasgow scales are not that sensitive to pick up the small changes that we see during rehab. So coma recovery scale revised is the one which we use here. Briefly capping on the definitions, what was described as coma, we generally don't get patients obviously in coma. Maybe once in a while we do get who fit into this criteria described as coma. By the time they come to rehab, they're usually out of coma. I also have to mention that there are no subacute facilities for rehab for children in New Jersey. So because many of these patients at this level won't qualify for acute rehab in adult places, where they first would end up in a subacute program, then transition to acute rehab. So in children specifically, so we had to develop a comprehensive inpatient rehab program due to those restrictions. And obviously insurance monitors weekly with progress notes. So this has been very useful also to document gains that are made not only in therapy, but also involvement of the family with family teaching and transition planning. So coma obviously described as eyes are closed, there is no awareness, there are sleep-awake cycles are absent, there is no command following or speech, reflexive responses to painful stimuli, autonomic functions are reduced. If we do some metabolic studies, there is a reduction almost 50 to 70% of the normal brain function. And it's a result from diffuse brain injury and usually lasts from 2 to 5 weeks. And it's a transient period during acute trauma recovery. The more common ones, what we call as unresponsive wakefulness syndrome, also previously more known as vegetative state. Patient is awake, but there is no awareness. Sleep-awake cycles are preserved. Autonomic and brain functions are preserved. Verbalization and voluntary responses are absent. And brain metabolism is reduced to about 40 to 50% of the normal. And what we see are cortical and thalamic injuries. Then move on to minimally conscious state, where the responses are still inconsistent, but there is awareness. Unable to communicate functionally, but may show verbalizations or command following. You could see some emotional behaviors or visual tracking may be present. Autonomic functions are preserved, and thalamocortical tracts are partially preserved. And brain metabolism reduction is to 20 to 40% of normal. Nowadays, minimally conscious state, there's also plus and minus, plus being those have more consistent following of commands. Also, sometimes, we are concerned that patient may be locked in, but this usually doesn't happen with diffuse axonal injury. This is very much restricted to brainstem infarcts, but just to be aware that generally with traumatic or hypoxic or other type of acquired brain injuries, we do not see this syndrome. Where if we do EEG or some functional scanning, they are pretty close to normal brain functioning. So we developed this REST protocol. REST stands for restful recovery. Again, more therapy does not mean faster recovery. That sometimes is very hard for the parents to be convinced that more stimulation you provide, constantly playing music or something else, it will make faster recovery. And this has been proven in literature that healing brain requires significant rest periods. There's a significant amount emphasis placed on education, not only on the treatment staff, but also with families, because that's been a significant area of concern, because families were not being were lacking education and realizing when they really have to discharge in 3 to 4 weeks to understand the whole scope of recovery. sensory stimulation, exposure to stimulation in a controlled manner, which we'll go over a little more detail a little later. And therapeutic interventions. Each patient's therapy is individualized, and medical and therapy and nursing are all working together. So this is what is an outline of our REST program. Our admission criteria for REST are with any acquired brain injury, with traumatic or acquired brain injury like a stroke. Our cutoff period is 6 months post-trauma. For anoxic injuries, it's 3 months post-trauma for obvious reasons because of natural course of recovery. We generally get patients anywhere from 2 to 4 weeks post-trauma from acute care. Ages are 2 to 21, functioning at or equivalent level to Rancho scale 1 to 3. Our discharge planning starts right on admission. And discharge criteria for the REST program is emergence from minimally conscious state and showing consistent purposeful responses to environmental stimuli. But there's also a limited time frame for this program. If there are no significant changes within the first 6 weeks, we are planning discharge right from first week, but definitely by 6 weeks, we discharge the patient from the program. Discharge plan involves family and team members, and generally they are transitioned either home. Majority of the children, even though they are functioning at a significantly low level, they are transitioned home, or some do go to skilled nursing facility. As you know, there are always discharge delays, and we continue to support family, and but if they stay beyond our usual length of stay, the therapy schedule is modified. Now, we have adapted many of the management recommendations from the 2018 standards, which was published and also talked about by Dr. Finns today morning, to use a standardized neurobehavioral assessment to monitor patients with disorders of consciousness. We have to do serial evaluations because one evaluation may not give a clear picture. The arousal, the sleep-awake cycles may be altered. So we have to do shorter therapies and frequent evaluations. So optimal arousal state to assess level of consciousness is extremely important. Identify and treat medical complications to optimize recovery. Definitely this is here, the medical has a significant input. As you know, patients are coming from acute care who are much more sicker than we used to see 20 years ago. Our REST protocol and the role of MD. These are certain areas definitely we focus on, but it's not limited to these. Hypertonia is a significant issue with initial management. Spasticity is painful, so you may not be getting the ideal responses if the patient is extremely spastic. So we have an aggressive protocol for managing spasticity using medications as well as more invasive techniques. Pain management, as it was mentioned earlier, even in the morning talk, especially if they had fractures, the responses are going not to be ideal if the pain is not controlled properly. Infections are easy to treat, but most common ones, pneumonia and UTIs, should be addressed very early. There are some conditions which are more specific to brain injury, like the paroxysmal sympathetic hyperactivity, especially with hypoxic injuries. It can be as high as 30%. With traumatic injuries is about 10 to 12%, which these have to be addressed. Otherwise, they would not respond to a structured stimulation program. Dealing with pressure hydrocephalus and use of neurostimulants. So paroxysmal sympathetic hyperactivity, this again, many of the patients are coming early from acute care, and this is very common phenomena. And you have to control this set of symptoms if you're going to see any meaningful responses. This is a sympathetic overreactivity to non-painful stimuli. Features persist for greater than 3 consecutive days. Features persist for greater than 2 weeks post-duration. And this was the diagnostic criteria that was published in Journal of Neurotrauma. Symptoms persist despite treatment of alternative differential diagnosis. Obviously, this is a diagnosis of exclusion, but the main 3 criteria that are usually mentioned is diaphoresis, dystonia, and hyperthermia. So during treatment of paroxysmal sympathetic hyperactivity, you're trying to minimize that may exacerbate some of the symptoms, like minimizing noxious stimuli, controlling infections, addressing constipation. There may be decubiti, heterotopic bone, undiagnosed fractures. And there's a whole lot of medications that have been tried. But at Children's, we developed a protocol using clonidine, propranolol, and Neurontin combination. So usually the first line is clonidine, and we can gradually add on the second line, propranolol and Neurontin. You have to maximize one medication dose before jumping to the second and third line. Also, when you are planning to taper medications, especially if they're on clonidine and propranolol, try to taper propranolol first. Otherwise, if you remove the clonidine, then you get paradoxical hypotension with propranolol. That you have to be careful. We also found Neurontin to be extremely useful for treatment. Post-traumatic hydrocephalus, we are worried about patients who have pressure hydrocephalus. Hydrocephalus ex vacui is not uncommon. That occurs anywhere from 40 to 80% of the patients with severe injuries. But this is again pressure hydrocephalus. There's a higher incidence with ventricular and subarachnoid hemorrhages. Post-traumatic hydrocephalus, also you have to look at influence of craniectomy on the CSF circulation. We've been getting more patients, especially in the last 15 years, who have had hemicraniectomies as part of the initial treatment of intracranial pressures. CSF outflow after craniectomy decreases twofold, and also the brain compliance increases. And if you get a patient who had just had cranioplasty, they are also had an increased risk of having hydrocephalus, because after cranioplasty, the expanded ventricles may obstruct the lumen of the cortical subarachnoid space and slow the CSF outflow. So these are some of the things you have to look out for to prevent increased morbidity and have a successful inpatient rehab. Neuromodulation, of course, there are many medications that have been used, but the one that is most commonly described is the amantadine. Again, in the randomized trials, the youngest age patients that were enrolled was 16 years. But again, we have extrapolated some of the findings to our pediatric age group. And amantadine is a safe medication, 90% excreted in the urine unchanged. Peak onset is about 1 to 4 hours post-ingestion, and acts by dopamine release, delays reuptake, also NMDA antagonist, as well as directly acting on postsynaptic dopamine receptor. Generally, the dose described was 400 milligrams per day in divided doses in adults, but we start with 5 milligram per kilo per day in 2 doses and go up to 10 milligram per kilo per day in 2 doses. This was one of the amantadine data. Again, the days that patients were in rest with amantadine was less than those patients who were without amantadine. Now, most patients were evaluated whether they would benefit from amantadine, but if they had increased storming episodes, then those patients would not be appropriate for using a stimulant medication when you're trying to control storming. We had a total of 67 patients, and 34 patients we were able to treat with amantadine. Out of the traumatic injuries, 20 patients were appropriate out of the 31. And among the anoxics and other brain injuries, there was less degree who were appropriate for amantadine. Was there a change in CRS scores? And out of 36 patients with amantadine, 24 made significant change, whereas not on amantadine also made improvements. They were much less. And when we looked at the initial CRS score, some patients came on amantadine from acute care. They also scored a little higher on the CRS score on admission. At discharge, there was a significant difference on patients who were on amantadine and those who were not on amantadine. And if you have multimodal evaluations that are available, again, according to practice standards, functional scans can be useful. Multimodal evoked potentials like the short latency or the long latency evoked potentials can be done. We generally do as a baseline brainstem evoked response on most of our patients here. But what we found is they are not that useful in prognosticating unless they're highly abnormal, like absence of N20 on the somatosensory or absence of wave 5 on the brainstem. If you have fMRI scan capabilities, again, it gives a highlights the picture where in a vegetative state, there is significant reduction in functional activity. But again, the gold standard, I would say, is still the clinical exam. Diffuse tensor
Excuse me,
imaging.
Dr. Yalamanchi, we would like to have when would be a good time for Danielle? Because we're nearing the end. We have about 12 or 15 minutes left at most.
Yeah, okay. I'm done in a minute.
Okay.
Okay, so diffuse tensor imaging, like was mentioned earlier, again, it has been more used to check on the water molecules along the axons. That was a normal picture, and this is what looks like post-trauma. And going through PET scan, again, a very useful tool. On the right side is unresponsive wakefulness syndrome compared to the active normal metabolism in a normal brain. So these additional tools are useful if available. Again, if you're attached to an academic center, you may be able to may get some of these investigations done. Now, we'll move on to more specific therapy aspects in our program, and Daniel Duddy will continue from here.
Lois, what's my time check? 10 minutes? Oh, okay. All right. Hi, everybody. I'm Danielle. I'm going to kind of go through this a little bit quickly, but I'm going to speak to kind of what Dr. Y was talking about a little bit more in depth about the role of the therapy team in the REST protocol. So obviously, we do serial evals, trying to time different times so that we get clearer snapshots of the patient's functional level. And it's definitely a multidisc team. We have, closely working with medical, nursing, respiratory therapists if needed, as well as the rest of the multidisciplinary treatment team. Okay, so restful recovery, we really try our best to provide that here in terms of making sure that the environment is quiet. We have a specific sign that goes up on the room so that everybody's aware that the patient is on the REST protocol, so that when they are in the room, we can minimize stimulation, so that when we are providing treatment, it's actually given in a very specific way so that we can monitor their responses. That way their room is blocked out for specific amounts of time so that all of these environmental pieces are kept so that they can get that restful recovery they need. We make sure we cluster their care so that if nursing needs to do a procedure or something has to be done from a nursing perspective, a therapist might join in or tag on at the end of that so that they get a specific time frame to rest. So then our next piece is emphasis on education. So this is probably one of the most important pieces of our protocol. It's really looping the family in. It can be very overwhelming and many considerations go into education. But the research shows that the more family involvement, the better outcomes in terms of getting our patients and their family home. And that's ultimately our goal with this protocol, is families being able to take their children home. Okay, so again, emphasis on education, make it meaningful. We try to incorporate anything that would help the parent and child's quality of life, and things that are familiar and things that they like. You can see the list here of all different ideas of sensory items. So we do a very extensive intake, and also monitor their responses to different stimulation. So we always want to make something that's positive, accessible to the patient. This is just how we kind of document and make sure that we're tracking. We do it bedside. We have a log that everybody can kind of use for a quick snapshot to know what stimulation was provided to the patient. And then we can obviously track it electronically in our medical chart. So then we're moving on to the S in our REST protocol acronym. So sensory stimulation is the big component here, that we really try to make sure that we're giving consistent sensory stimulation and avoiding noxious. Noxious is going to, have adverse effects to the patient and their healing and recovery in their brain. So we really try to use things in a way that is safe for the patient and family, and we teach the family how to utilize that. So obviously you can read the different techniques that we use. This picture down here is just an example of a box that we have for every patient that's on the REST protocol, that has all different types of sensory stimulation for all of the areas that is bedside for them to use. So this pretty much kind of goes how we provide the stimulation. We make sure that, again, we're tracking. So if it is noxious, we're not going to keep recreating that noxious stimulation. We're going to try to limit it or avoid it. We also want to avoid overstimulation and habituation to the stim. So our protocol is written that if you're seeing any noxious response, that you stop the stim immediately, and you give the patient at least 15 minutes to recover before you start another stimulation. So this is obviously the responses we're looking for are generalized and localized. A lot of the times we're not seeing any generalized even responses when they come in. So we obviously are looking for that at the start. And then a lot of the times we'll start to see localized responses, and this is how we monitor how they're doing, and this is how we would educate family on what to look for, so they know how to appropriately assess the stimulation and whether it's being positive or negative for the patient. Okay, so obviously within this REST protocol, we're still going to do all the traditional things we would do in a rehabilitation model. So making sure we're doing range of motion, early mobilization, getting them out of bed, getting them into positioning equipment. So this is our multi-disc team here listed. Everyone has their role, and it's super important that we all communicate and we're all together for helping these patients. We meet weekly for all of our REST patients, specifically for this team and protocol, so that we can all, collaborate and make sure we're making adjustments as needed. So just quickly, some of our data. This is our admission demographic. So we've had 67 patients since 2014 that we've been tracking. The protocol started before that. This is just when we started collecting and looking into the data. So, the 31 is TBI, the green, and 28% is anoxic brain injuries, and then other ABI are kiddos who've had sustained AVMs or have residual effects of tumors or tumor resections. So significant comorbidities, this is important to note because it will impact how our children do. So obviously if they're more medically fragile, it's going to impact how they recover and just how we adjust our treatment. Like Dr. Yalamachi said, everything is going to be individualized to our patients' needs. But just so you know, some of the comorbidities that we're tracking are respiratory, so vent dependence, significant seizures that might affect care and ability to accept this stimulation, and multi-trauma, so whether it's orthopedic or multi-organ involvement. So our admission scores, this kind of just reviews some of the evals and assessments that we're using to track this. So, you know, Dr. Yalamachi already went over them, but we utilize the GOS, the DRS, and the CRS. Each discipline kind of takes ownership over the different assessments, but we're all collaborating together. We try to space out our evaluations. So again, that we're seeing a snapshot. And you can see the reason we use multiple scales is because they're all a little bit different and a little bit more sensitive than others. So we like to have a variety of information on our kiddos that are, you know, it's typically hard to really see the changes, but according to the scales that we're using, we are seeing changes, and we're seeing consistency in the scores going up on all of the scales. So it's been really positive to track this and know that we're helping our kiddos. So they are making progress, even if it's a small change. Okay, so if a patient has been making significant progress within the REST protocol, or if they have been in the program longer than 8 to 10 weeks, they will transition out of the protocol to a more traditional rehab model, and we'll make adjustments in their schedule depending on what their needs are. There have been many children that continue to progress out of the REST protocol, meaning they, you know, improve into a more functional state and can tolerate more traditional therapy, including aquatic therapy, you know, things that are a little bit more involved.
5 minutes, Danielle.
Thank you. So our discharge disposition, this slide shows that, you know, we're really happy that we were able to get 68% of our kiddos home, which is really amazing based on how they came in. So it goes to show that that education and that restful environment and that sensory stimulation is really helping them. So 19% went to long-term care and 13% were discharged to acute care. So like I said before, our goal is always home. So we provide these families with whatever training and education they will need to safely take their child home. We found that better outcomes with a familiar environment. So some of our kiddos will continue to progress. Unfortunately, we have not been tracking data on them post-discharge, which I think should be our next venture, because it's amazing how well some of our kids do. Oh, I did it. Good. So here's a list of our references. The data, just to note, the how we've been collecting our data is this REDCap electronic data. It's a tool. I just have to note that that's what we've been using to collect our data. And then this is what our REST protocol sign is. Please lower your voice, keep noise to a minimum. So this helps our staff know, even if they're not, you know, individually or specifically working with a child, they know that that's what that means. They know that in that environment, even our environmental services crew is trained on the REST protocol. So when they are doing cleaning of the room, they know to do it when the patient is either out of the room or to be very cautious and quiet while they are performing that in their room. So this goes on the outside of the door so that everybody is aware and everybody can help provide the best environment for recovery for our kids.
Danielle, I think we're going to have to stop so I can present some questions. I hate to do it. I hate to stop you.
No, we're good. We're good. I got through it quickly.
Oh, boy. Okay. Questions, and this is to any of the presenters. From Diane, I'm interested in the studies of brain oxygenation since the initial studies were challenged about the data. How have the recent studies changed? Oh, Dr. Sukov, you're on mute.
Yes, thank you. Well, let me put it this way. I'm not going to profess myself as an expert in this specific topic, because I think that is a more question for the intensivist and neurosurgeon. There are a number of initiatives, and there are a number of startups that are working on a variety of different markers, that as far as I know, have been initiated, and some of the issues that they're studying are very proprietary. I think that they're looking for around 20 different markers, or even more so, to prognosticate the outcome of the traumatic brain injury. The whole idea behind the using microdialysis and sampling the tissue at the time of the brain injury is very notable, in terms of that it can, if you have a specific marker that shows the rise or fall, and you can correlate it with the outcome, then you can actually prognosticate the overall outcome of the brain injury. And it's a very I don't want to cite anybody. I don't want to give any information, because I think that it's very proprietary. A lot of startups are working on this type of data. Maybe Dr. Yalamachi knows more than me, about that, but I have no other information.
Dr. Yalamachi, do you want to add anything?
Yeah, I have to say, over the years, we have seen many of these markers that are being used. But to prognosticate, if that is a question, I think still we come back to the basic gold standard, that's the clinical exam and the rate of progress. I think we have gone through this, even the evoked potentials and blood levels of certain breakdown proteins in the brain. They have not, we haven't been able to generalize those type of tests, but I think clinical exam still falls back, as certain aspects of clinical exam are useful for prognosticating. But again, rate of progress is the key for long-term prognosis.
Thank you. Another question. This is from Heather. Have you seen an increase in sports-related TBIs in children? This is to anyone.
Well, this is a question for in our talk. We talked about moderate to severe brain injuries, and there's also mild traumatic brain injury, concussions, and the awareness about concussion has risen within the last maybe 15 years tremendously. And to that extent, there's also a variety of different precautionary measures that have been taken by the active parents, active groups, active associations, et cetera, et cetera. So in order to answer this question specifically, we have to define what do you mean by sports-related injury, and in which category you are looking at. You're looking at a mild traumatic brain injury or moderate to severe. From a moderate to severe brain injury, I think that, as far as I know, I don't have that statistics, specifically. I think that we don't have a national data about it. And I think that overall, the whole purpose of our presentation in pediatric rehabilitation in general, and pediatric rehabilitation of brain injury, is to raise awareness that actually children exist, and that children do need brain injury research. And it's actually kind of a hidden subject in a way. Everybody's talking about it and talking about many different aspects, but we need to really consolidate data around the country and find out more about the variety of different brain injuries. How did they present? What's the story there? How you can describe them, including sports-related injuries.
Thank you. And the last question. How do you balance the outpatient community-based therapy versus play while habilitating?
This is very interesting question, because it's the children's work. It's play, right? When the adults are undergoing rehabilitation, they we're talking about vocational rehabilitation. How are they going to go back to work? Really return to play is the subject that we need to discuss for the children, because their play, it's their work, and we should all be children at heart. So we should also find time to play, right? So, and habilitation aspects of it, it's really unique for the children, because children, some of children that we're talking about, they don't know the skill, they haven't developed it. So it's a unique type of approach for the pediatric brain injury rehabilitation altogether, because you're combining play that habilitates you to learn certain skill that you eventually will use as a vocational skill to be employed successfully as an adult individual, and to earn your living and to be a productive member of society. It's a kind of a far detached model for the brain injury models that exist for the adults. So I think that incorporation of these concepts are very important for overall brain injury association, saying that this is a very important subject for the pediatric rehabilitation at large, and that concepts have been formulated, but they have not really gained traction, probably from a funding perspective or from this reimbursement perspective, and other things that we're all struggling with in different rehab settings, including outpatient settings as well.
Okay. There is one more question that came in. It's for Danielle. In your clinical opinion, do you think it would be beneficial to continue to address sensory stimulation in an outpatient rehab setting for those patients who are discharged home but are still in an altered consciousness state?
Yes, absolutely. Dr. Yalamachi could also chime in, but yeah, so that's why the family education is so important, because clinicians on an outpatient center might not necessarily know our specific protocol. We do touch base with them and explain, how we administer the STIM, but we really empower the families. They're here with us almost daily, seeing how we do it, and we train them so that they're really the leaders and able to kind of continue that plan of care when they go home.
Thank you. Dr. Yalamachi, did you want to add anything?
Yeah, I think it comes back to a lot of family training, because if the patient is functioning at, we're talking about minimally consciousness or a chronic vegetative state, we may not be recommending, going for individual therapy. They would be recommended for home-based therapy. And many of those aspects are, carrying over therapy with parents. I think parents become quite a center where they are coordinating a lot of their care once they're home. Because a high percentage of children are going home, in fact. So it's basically family is empowered to carry on many of those sensory stimulation therapies.
Yeah, and then just to add, I'm sorry, just to add, the focus, the shift will turn also to quality of life. So if a family really wants to be able to do something with their child, even if they are still in a minimally conscious state, we teach them and train them, how to adapt the environment, what equipment they'll need, how they're going to get them in and out of a car and get them to, a place that's meaningful to them. So the focus might shift a little bit towards the end in terms of that quality of life, like Dr. Wide was saying.
Education, education, education.
Yeah.
Well, I want to thank all three of you. It was a wonderful presentation. I just wish we had more time for you, and maybe that'll be next year's piece as well. But it was highly stimulating, very, very informative. And I just wanted to remind people to please make sure your names are in the chat room and do the evaluations. And it's now time for the exhibits. Thank you so much.
Thank you.
Thank you.
Lois.
Take
Bye-bye.
care.
Bye.
Thank you.
Bye.